So, hi guys, welcome back to the channel. Today, our topic of discussion is postnatal or a postpartum or a post-cesarean case presentation. So, history taking mostly is very important in postnatal patient and also the examination. So, I'll tell you about both the history taking and examination in short in this video. And this topic is very important for you as an undergraduate or a postgraduate student. In undergraduate student, you can expect this as a long case in your exam in practical exams, and for a postgraduate student mostly this is a short case presentation, so you may be asked only about the summary. So I have included how to present a summary also. I have given an example of a sample case, so you can just you know just apprehend that how to present it. And also for DNB student, postnatal case presentation is a part of your practical examination. So please listen to the video carefully. And already you have seen my obstetric history taking. So from there you have some basic ideas, and that video will help you in understanding this also. So if you have not seen yet, please go and see that first, obstetric antenatal history taking, and then come back to this video. Okay, so let's begin. So firstly, as you all know, in any of the subject, medicine, surgery, or obs and gynae, you need to ask about the patient particulars. So in a PNC case presentation, you need to ask about the name, address, education of a patient, as always. Then also about the husband, name, age, education of a patient, about the socioeconomic class of the patient. You need to ask the LMP and EDD, obstetric score. Okay, she can be para 1 live 1 A1, or she can be P3 L1 A1. Okay, so you even so you need to ask about the obstetric score. There will not be any G because she is not a gravida anymore. She has given birth, so it starts from P only. About the postnatal day or postoperative day, like she is postoperative day 2 of cesarean section or postnatal day 3 of vaginal delivery. Okay, types and mode of delivery, whether it was vaginal or cesarean or instrumental. What was the indication of instrumental delivery if it was the case? What was the indication of cesarean section if it was done? About the date and time of the delivery. Every mother knows about the date and time of her baby, when her baby was born. So every mother will be able to speak about all of this. Okay, about, and also you have to mention the date on which you are examining the patient. Okay, so after patient's particulars, as always, you ask about the chief complaint. So the chief complaint in a postnatal patient can be fever or pain abdomen or excessive bleeding per vaginum, foul smelling discharge per vaginum, difficulty breathing, burning micturition, or swelling of legs. Or there can be no chief complaint, and you patient may say that I have no complaint, I am fine. So in your chief complaint, it's not that patient don't have chief complaint. You have to say that patient has come for routine checkup, or routine checkup has been done for the patient. Okay, if patient is admitted in the ward, which in most cases patient will be, and in most cases you may not get any complaints from the patient, so you need not mention, just mention about the routine checkup of the patient. Okay, history of present complaints. If she has any complaint, you describe the complaint. If she has none, then just skip this point. History of present pregnancy, very, very important. You have to explain this history in details. Okay, so what you should be including in history of present pregnancy? First, if it was a planned or unplanned pregnancy, if spontaneous or assisted conception, if she was a booked case of this hospital or not, how many visits she had in this hospital or wherever she was following. about the blood investigations and the ultrasounds she has done. If she has taken folic acid, iron, calcium tablets, or any other medications, like if she was a known case of hypertension, if she was taking labetalol or nifedipine or whatever, if she was a case of diabetes, was she taking insulin or metformin or what? So you have to ask about other medications also, any additional medication also if she was taking. She has taken 2 doses of tetanus injection. When did she perceived her first quickening? At what months or weeks? If there was history of any nausea, vomiting, high BP, fever without rash, any radiation exposure, any teratogenic drug intake, and everything. Like you ask in an antenatal case presentation, in this also you have to ask that way. If there was history of raised BP, bleeding, leaking, urinary complaint, anemia, or any thyroid disorder, if she had any history of hospital admission, any blood transfusion, any FCM injection, so you need to ask about all these points in history of present pregnancy. Now, after history of present pregnancy, you have to ask about the dietary history of the patient. And how do you take the dietary history? The most common one is 24-hour recall method. I'll teach you dietary history in details in a separate video. Just for this video, remember you take by 24 hours recall method, and then you calculate the total calorie intake in the last 24 hours and the total protein intake in grams, and the total weight gain during her pregnancy. So after history of present pregnancy, including the dietary history, you ask about the history of labor and delivery, gestational age at onset of labor or at the time of cesarean delivery. If she she had gone into labor, if it was spontaneous or induced or augmented. Okay, you have to ask in patient language if she presented with complaint of pain abdomen or she was admitted with high BP at how many weeks, and then she was given some medication to start her pain, or when she was admitted her pain was not adequate, and so some saline or some infusion was started to increase her pain. Okay, so you have to ask in patient's language. Then you ask about the duration of labor, her membrane leaking status, the color of the liquor. Patient will be able to tell you if she had leaking or not at presentation, what was the color of her liquor. CTG findings, if patient is able to tell you have to mention. Like she may tell that her fetal heart rate was not going good, and so doctor had taken her for cesarean as the fetal heart rate was dropping. So at least in vague language also she'll be able to tell you, and you should be able to pick up what had happened, like NST or CTG was being done and it showed fetal distress or bradycardia, and then she was taken up for cesarean section. If she had been given any, analgesia, any labor analgesia or not. If there was any instrumental delivery, then what was the indication? If cesarean, then it was elective or emergency and the indication. If there was any complications or, perineal tears during vaginal delivery, if active management of third stage of labor was done or not. If it was not done, obviously, patient will be able to tell you if she had excessive bleeding, any blood transfusion was done or not, or she had been put another cannula in her other hand. So all these things she will be able to tell you. You just need to hear the patient with some patience, and you'll be then able to make out the history. Okay. Now about the neonatal history also. This is a very, very important part about the date and time of the birth. If it was vaginal, cesarean or instrumental, if it was a live and stillbirth. So stillbirth cases may not be given to you as mother is already depressed. So mostly live baby will be given to you only. So you'll be able to see baby by mother's side. If you are not able to see baby by mother's side, then you should ask about the baby in very subtle tone. like where is your baby? Then patient may say, okay, my attendant has taken the baby and roaming here and there, or the baby is admitted in neonatal ICU. So she will be able to tell you, and you just need to ask very patiently and in a settled tone. She'll be able to tell you about the sex of the baby, about the birth weight. ABGAR, she may not be able to tell you, but if she is quite educated and she knows about this term, then she may be. So you should ask, and if she is not able to tell, just skip. Okay. And if there is any history of NICU admission on any day of the baby's life, okay. Then, in the postnatal history, this is another section after neonatal history. You have to ask about both the mother and the baby separately. For mother, you have to ask about any pain or any vaginal discharge, which is lochia, any history of fever, if she is able to breastfeed properly, if there is any complaint of breast pain, tenderness or hardness, patient will be able to tell you that my breast has gone very hard and I am unable to express milk. It is very painful during expression. So she'll be able to tell you everything. If she's able to pass urine like without any complaint, or if there is any dysuria or burning sensation. So all this she will be able to tell you, and you have to ask in your history. What the bowel habits, sleep, diet, if she is mobilizing well, if she is walking, or she is just confined to bed, and if what is the emotional status of the patient, you will be able to know while talking to the patient herself. If she is answering you properly or not, if she seems very disinterested or very, depressed, you'll be able to make out from while talking to the patient. Okay. After asking about the maternal status, you have to ask about the baby status also. If baby is breastfeeding well, if baby is passing stool and urine, how many times a day baby is passing such urine and stool. Um, Patient may say that my baby is crying so much or my baby is not crying at all. So accordingly, you have to deal with the patient, and about if the baby has gotten jaundice or admitted for jaundice in NICU or for whatever reason, patient will be able to tell you. So just remember, you need to ask these points in history. This should not be missed. Okay. After postnatal history, you ask about the menstrual history. You have to take these points. After menstrual history, you ask about the obstetric history, if it was a consanguineous or non-consanguineous marriage. This is very important to know about it. There can be any risk of genetic diseases. What was the age at marriage, and she is married for how many years. And you have to present the obstetric history in tabular form. Like if she is suppose para 2 life 2, then or para 3 life 3, then you have already mentioned about the present pregnancy and the present delivery. So you have to mention about the last 2 pregnancies in this tabular form. So year, if it was a spontaneous conception or not, if she had any eventful antenatal history or any complication, her intrapartum status, if normal delivery or normal vaginal delivery or instrumental or cesarean delivery, indication about the status of the baby, the sex and the age of the baby, if baby is doing well and achieving normal developmental milestones or not, and history of any contraception and the space between previous birth. So all these are very important. You need to ask in OBS history. Again, past medical and surgical history, any history of diabetes, hypertension, thyroid disorder, all these things, any surgeries, any blood transfusion in past, then history of cervical screening or vaccination, HPV vaccination, you have to ask. In family history, history of chronic medical disorder or genetic disorder, twins and congenital anomalies, any history of any cancer in the first and second degree relative, you have to ask. Okay. Personal history, as you all know, diet, sleep, appetite, bowel, bladder, addiction, allergies, and contraception. Either you ask in the OBS history or in the personal history. You don't need to mention it twice in everywhere. So just mention it either in OBS or personal history. Then comes general examination. So there are some prerequisites about general examination which I have already taught you in previous videos, like bladder emptying, privacy, consent, presence of female attendant, well-lit room, position of the patient. So all these are important prerequisites which you should not be, should not forget. And what do you mention in your general examination? Patient is alert, conscious, cooperative. She is oriented to time, place, and person. Her build is average or well built, or poor, or nutrition is poor or seems good. Hydration is poorly. Patient is dehydrated or not. Her orodontal hygiene you have to mention. Then you mention about this pylorictus, cyanosis, lymph nodes, edema, and everything. You take patient's height, weight, and BMI. You take the vitals. Now the most important thing is breast examination. Why I have mentioned it in red? Because many of the time we forget to take the we forget to look for the breast examination because we are just in a flow. But don't forget, in PNC case presentation there are few things which if you miss, you are just missing out on the numbers in a very large margin. So you should not forget about breast examination in a postnatal case. And what do you look for in breast examination? You look at the nipples, if it is cracked or inverted, because if it is so, then patient will be having problem in breastfeeding. Okay. If there is breast engorgement, any tenderness, swelling, redness, if while on examination, if you are compressing the nipple, there should be milk secretion, and if there is milk secretion, you also note the color and the consistency of the milk. So after breast examination, you do systemic examination, CVS, RS, and CNS. After that, you do per abdomen examination. In inspection, there is nothing more than just looking for the scar and the stretch marks. In palpation, this is very important, palpation in a PNC case. You have to measure the fundal height of the uterus in relation to the umbilicus. So for this, you need to know some theory also, which I'll teach you in upcoming videos. Uh, at what number of postnatal days the uterus should be present in which place in relation to the umbilicus, 2 centimeter below or 5 centimeter below or just above pubic symphysis or just at the level of umbilicus. You should know at which day you are expecting the uterus to be at what position, and that is how you will know if there is proper involution or subinvolution of the uterus. Okay. Involution means uterus will get retracted in size time by time. So at what time, what is the position of the uterus? What is the ideal position? And if it is not in the ideal position, then there is some problem. So that is why it is very important. Also, you check for the uterine tone and the tenderness, which indicates infection, and you auscultate the bowel sounds. Then you do local examination. In undergraduate patient, you might not need to do it. That will be told by your, respective college personnel if you need to do or not. But for a postgraduate student, you need to do it. In a vaginal delivery patient, you need to check the episiotomy wound or the perineal wound if it is intact, if there is some infection or discharge or pus coming out of here or any stitch given away. So you have to check all that. You have to look for hematoma, swelling or redness, any infection, and you have to note the lochia, if it is rubra, serosa, alba, what it is and the amount, and how is the smell, if it is foul smelling indicating any infection. So you have to look for that. Again, lower limb examination given in red means it is very important and we tend to forget it. So in a PNC patient, you have to check the lower limb, both the legs, for edema, tenderness, varicosities, and any other signs of DVT. Okay. So we have to rule out DVT in a postnatal patient. So after examination, you have to present the summary of the case and you have to give your provisional diagnosis in 2 to 3 lines. Now, I'll tell you about a sample case presentation. So till now I have told you what to write in your papers when a case comes, but while presenting, mostly you need to present it in a summary fashion. So until you have taken the case, you don't know how to present a summary. So that is why these points are very important, whatever I have taught you. So after taking these points, now you write your summary in this way, in this manner you can write. And just remember, every examiner and every teacher and consultant may have some other opinion about how to present a case, what to include, what not to include, what is important for them and not. So never argue, just take their points and write those points in your notebook or wherever you are writing, and include that in your case presentation. Okay, so there is no perfect case presentation. I have tried my best to assemble and give it to you, but there might be some difference of opinion. Okay, so just bear with that. So how do you present postnatal case? So we have to talk like this. I'm presenting case of Mrs. XYZ, a 26 years old para 2 living to abortion 0, who is postnatal day 2 following a full term emergency cesarean delivery performed on this date at ITNA time for whatever indication. Now you came to the history of present pregnancy. She was a booked case with regular antenatal follow-up. Her pregnancy was unplanned, spontaneous, and confirmed at 8 weeks of gestation. Her antenatal investigations were normal. Her blood group was positive or negative. This is very important, blood group, because if it is negative, Rh negative pregnancy, then you need to know about the blood group status of the baby and the anti-D injection status of the mother also in the postnatal history presentation. So this is very important. Her ultrasound at this and these weeks or months were normal as per patient, and her fetal growth remained appropriate throughout pregnancy. Patient will tell you, okay, my fetal growth was appropriate at each visit, or there was some lack in growth as per doctors. Okay, she will tell you. She did not had any diabetes, hypertensive disorder, or thyroid disorder, or any other medical illness. She had received 2 doses of tetanus, and she was compliant or non-compliant with iron, folic acid, and calcium supplementation. Now you come to history of labor and delivery. At 39 weeks or whatever weeks and days, she presented in spontaneous labor with regular painful contractions. On admission, her vital signs were stable. The fetal heart rate was reassuring. Patient will tell you that they checked the fetal heart rate on admission and they told that it was normal. So fetal heart rate was reassuring. Labor progressed until the active phase. She will tell you that doctor told me that while I was 5 centimeter dilated, then the fetal heart rate dropped, so they had to take me for cesarean. So patient will be able to tell you this. If she is not able to tell you this, then you need not mention about active phase or latent phase. So labor progress until active phase, when persistent fetal bradycardia was noted on CTG machine, and in view of that, an emergency cesarean section was performed. She delivered a live male baby weighing itna kg who cried immediately after birth. The placenta and membranes were delivered completely. There was no excessive blood loss or any other complication. Now, on patient currently is at postnatal day 2 and she has no complaint. Again, I told you patient may not have any complaint. So you mention here she has no complaint of bleeding, fever, pain, abdomen, headache, etc., etc. She is ambulating well, tolerating oral feeds, passing urine normally, and has passed flatus and stool. She is exclusively breastfeeding and the baby is feeding well. Okay. So you mention about the present condition of the mother and the baby. Now you come to examination. In summary, you need not mention about the, menstrual, previous OBS history, personal family history and all that. Summary is like the positive and the important findings. Okay. And the important negative findings also. On examination, she is conscious, she is comfortable and afebrile, pulse rate is this, BP is this, and all this you mentioned. There is mild pallor and there is no fetal edema. On breast examination, the breasts are soft with normally verted nipples, and there is adequate milk secretion. There are no cracks or feature of mastitis, like I told you, swelling, tenderness, redness, etc. Abdominal examination reveals a healthy fanal still incision. This is the cesarean section scar with a clean and dry dressing. Abdomen is soft, non-tender. Uterus is well contracted, corresponding to ethnovic size, and is non-tender. There is no suprapubic fullness, means full bladder. So it means you have made your prerequisites. You have ensured your prerequisites. Okay. So perineal examination is unremarkable. Lochia is rubra, moderate in amount, without foul smell. Lower limb, very important. Breast examination, very important. Lower limb shows no edema or calf tenderness or any evidence of DVT. Now, if she knows about her postnatal HB status, she will be able to tell you. If not, then skip this point. So now you give a diagnosis, provisional diagnosis. She is a 26 years old, P2L2A0, postnatal day 2 following emergency cesarean section at term for non-reassuring fetal heart with an uncomplicated post-operative and postnatal course. Okay. And so the consultant may ask you about the management plan next. So you should be able to tell that I'll continue with the routine postnatal care with regular monitoring of vital signs, uterine involution, lochia, wound status, and breastfeeding status. I'll continue analgesics, iron calcium supplement, encourage early ambulation, adequate nutrition, and provide breastfeeding support. So when asked about the management plan in a patient who has no complaints, you should be able to tell this. If she has complaint, then you have to manage her accordingly. And you have to counsel patient regarding exclusive breastfeeding for 6 months, postpartum contraception, very important. Many a time we forget this point. Postpartum contraception is very important. And recognition of danger sign, neonatal care, and schedule follow-up at 6 weeks after delivery. Okay. So, I have tried to teach you in a compiled manner from many of the books and the sources. PNC case presentation is not given in a proper way like the ANC case presentation. So I tried to compile it. I think this will do for your exams. Then obviously if there are any extra suggestions or any extra points from your consultant or your teachers or whoever, you can add and always improvise. And if you have any doubt, you can ask me in the comment section. Please like and subscribe for more videos. Thank you.